Hello, good evening. Hello there. Someone's got their camera on. I'm just looking where everyone's coming from. Do please introduce yourself in the chat. It's fantastic to meet you all. We're just going to give it a little bit longer. There's still more people coming into the lobby. Oh, I'd like to know where people are coming from. So if you put your name in the chat, if you can access the chat, that would be amazing. Anjali, I can see you in there. Don't be shy. Has it frozen for people?
Oh, hi there.
Hello there. Can you hear me, Celine?
Yeah, I can.
Yeah, brilliant. Oh, that's great.
Do you want me to try and share my slides and see if it does?
Yeah, please do. Yeah, let's see if it will.
Yeah.
Yeah, it's a little bit confusing there, isn't it? Looking at all of us frozen. There's people coming in. There's Moira from Bristol. Hi, Moira. Great to see you. If you do want to introduce yourself in the chat, that would be absolutely fantastic. We're going to get going in a minute, but we just want to give people a chance to start. There's Shireen. Hi, Shireen. Lovely to see you. You managed to get out of work on time.
I did. Yes, I did.
And we're very excited about connecting with BOPA and what that might mean in the future. And we're going to talk about a little bit about that at the end. But lovely to see you. Shireen, we've got a couple of minutes. Do you want to introduce yourself? Putting you on the spot, but we're friends, so I can.
Yes, sorry. I'm in the car, so I won't turn on my video.
Oh,
but, yes. So hi, everyone. I'm Shireen, Professor of Oncology at Kingston University. And I'm also the Vice Chair of the British Oncology Pharmacy Association. And yeah, looking forward to seeing what we can do together. So yeah. Thank you for thinking of us.
Absolutely, fantastic. And we're up to about nearly 40. Should we wait till we get to 40, Celine? What do you think?
Yeah, that sounds like a good plan.
We're only a couple of minutes past. So I think we just give people a couple of minutes. That's great. Does anyone else want to say hi? Do please introduce yourself in the chat. We're trying to work out where people are around the UK and maybe even further. So that's great. And it'd be really good to see. We've got medical students. Thanks, Gemma. Great to see you. Chidnama in Preston. That's great. Adeniki in Leeds and Hull. Hi, how are you? We are now linked through Women for Oncology as mentor and mentee. So wonderful to see you. Great. Yeah, that's great to see. We've got a full range of people joining. So that's fabulous. Paige from Southampton. Great to see you, Paige. And Yasmin in Peterborough. I used to work in Peterborough many, many years ago. So that's fabulous. And Kings in London, Wales, we've got. Jess, great to see you. Right. Committee, are we ready? Have you pressed record, Celine? You've got it on record.
Let me double check.
Hi, Dr. Helen. I'm not getting access to the chat box.
If you are just coming in, if you can just mute yourself if you can. I know it's really hard because people will be coming in from work, finishing off in clinic, fetching kids, fetching partners, doing the shopping, doing everything else. But, oh, hi, Lewis. Great to see you. Hi, Dina. Wonderful to see you. I think we'll start. I make it nearly 50. So welcome, everyone. And thank you so much for sparing the time to join us in this inaugural meeting, Women for Oncology UK, and all that encompasses. And for many of us, it will mean different things. And why we are here, hopefully, as we get to know each other, we can share why we have all turned up today and what we're hoping to get from it and how we might shape this movement, this group of people, and what we can do together for our workforce, but also our patients. So for those of you who don't know me, I'm Helen Winter. I'm a medical oncologist and have been for many years. And I'm also very fortunate to be the SWAG Cancer Alliance Clinical Director. And I also have roles both at the University of Bristol and the NIHR. So I have lots of different hats. And I feel very lucky because a few years ago, it wasn't quite working out for me like it is now. And for many of us, there will be people on the call who at the moment are struggling with things, whether that's professionally or personally. But many of us will relate to having those struggles and having those challenges and having those dilemmas sometimes. And so I actually paid for some advice and I went to see someone. And the advice that I was given was, don't look back, don't kind of dwell on what was going wrong and not really happening for me at the time, but put all your energy into looking forward. And perhaps the most important advice was reconnect with your values. Why did you go into medicine? What makes medicine worthwhile to you? And so I'm just going to share those values because by reconnecting with those values, it's led me here today. And hopefully for some of you, that may help with reconnecting with what your values are. So firstly, as an oncologist, my values are about delivering excellence and the highest quality care and world-class outcomes. But we've got some challenges. We all know about those challenges in the NHS, but I absolutely believe that I have to strive to deliver excellence for all patients. My other value is about developing others, upskilling the workforce, hopefully ensuring that all our workforce feel valued and have the opportunities that I have been fortunate enough to get. So actually ensuring that people feel valued in the workplace and developing others. And it's just so lovely looking at some of the names that are of people that are joining. And I've been very lucky to connect through this movement, and particularly through Celine and Jess and the Women for Oncology Committee, largely from resident doctors and medical students. I feel very lucky as one of the older ones to actually be part of that group because they're teaching me so much in setting this up and how we might move things forward. But my final value was about ensuring equity and fairness. And so I just wanted to draw attention to those of you that haven't seen it yet. And perhaps, Celine, you can just cut and paste the link to the Cancer Research UK social deprivation report, because that is very sobering. And I do urge people to read that and say, look, as a movement, one of the things I would like to see us doing, as well as promoting women and leadership, which you're going to hear of much more in a moment from our amazing panel. But we really do need to advocate to ensure that the inequalities that we are seeing and that Cancer Research UK have literally reported this week, that we do something about that. So that's my call for action. That's a little bit about me, but I'm going to hand you over to Celine, who, as I said, is on the committee. And if it wasn't for Celine, nobody would be here. So I just acknowledge everything that she's done and driven. And Celine, over to you. And I want you all to have a fantastic evening. It's going to be informal. We're going to have 20-minute talks and then 10 minutes of questions from our three amazing speakers. But Celine, if you can just set the scene a little bit more. And I just want to acknowledge you publicly and thank you for all I've learned from you and all your drive in this.
Oh, thank you for the introduction, Helen. So I'm Celine. I'm an internal medical trainee up in North Wales at the moment, and I have the aim of starting oncology training in August. And I'm one of the founders of Women for Oncology UK. So what made us start the society? Although the proportion of females and males in oncology is equal, there is still a lack of female representation in oncology leadership and academic roles. There has been several studies that have shown that women are less likely to be invited speakers and board members of national and international oncology congresses, first authors of journal articles in oncology research, and leaders in oncology hospitals, treatment centres and research institutions. Thank you for completing the pre-event survey. We have received 43 responses, which were 41 women and 2 men. And we can see from the chart on the right that approximately 60% of participants believe that they have had less opportunities because of their gender. the 2 male participants felt they had more opportunities because of their gender. We can see here that around 75% of participants have experienced bias or discrimination from a senior colleague because of their gender. There was quite a wide range of opinions on what experiences people have had and what they think are the main barriers preventing gender parity in oncology. The most common thoughts were a lack of work-life balance, a lack of female professional self-confidence, lack of leadership development for women, societal pressures, and unconscious bias. The answers to this question were quite insightful, and there has been a range of experiences that have led you to believe that we need women for oncology. Common themes included noticing discrimination because of flexible working and childcare needs, noticing a lack of female role models and a lack of representation, and noticing an increased gender gradient in academic oncology. So, our solution is the Women for Oncology UK Society. We have formed it in conjunction with the widening Participation to Medics Network, and also inspired by ESMO, which is the European Society of Medical Oncology. We are a group of healthcare professionals at all levels of training, and we currently have 65 members from all over the UK. Our guiding principles. So our mission is to support and mentor female oncologists in the UK, encourage balanced gender representation, create a research platform, and perform patient advocacy. This is reflected in our vision, and our values are therefore equity, collaboration, and empowerment. Our activities include a lecture series, a mentoring scheme which is already up and running, and we currently have 36 pairs, and this provides one-to-one mentoring partnerships that help to support career development. We also have a networking channel on a platform called Slack, and this allows members to connect, share experiences and opportunities. You can scan the QR code at the bottom to join Slack, but we will share these details after the meeting also. The committee consists of myself, 2 oncology consultants, 2 oncology registrars, a clinical fellow in oncology, and 2 medical students. So that's just an introduction to how forming the society came about, and I will now hand back to Helen to introduce our first speaker of the day.
Thanks, Celine. And thanks to all the committee and everything that's gone on behind the scenes. But it is my absolute pleasure to welcome Helena, who's joining us. I don't know if you're still in clinic or you've just driven home, Helena, who I first met, I think, online several years ago, and then I had the privilege of meeting her and many of the ESMO Women for Oncology from across Europe last year at ESMO. And that was when I thought we really need to do something in the UK. There's a lot to learn from our colleagues in Europe, and there's certainly a lot for us to learn from Helena. So Helena is currently the chair of ESMO Women for Oncology. She is also a member of the ESMO Council. She was the founding member of Hellas, which is in Greece, and that has similar values. But I'll let Helena talk about maybe her motivation and also what she feels that we can learn from ESMO Women for Oncology. Helena, I'll let you come into screen and we'll start sharing your slides. Thanks so much.
Thank you, Helen, and thank you for this very nice introduction. Actually, I just drove home from work, and we are 2 hours ahead of you, so it's 8:15 here now. So I'm sure that women in oncology all over the globe are working like that, like nuts. And that's what I was doing for many, many years in the hospital where I'm working in my department, being the second in charge for a very long time. Even though I had spent almost 10 years of my life studying abroad, even though I was one of 3 people in Greece that had a PhD, in oncology from Imperial College. I was still number 2 for almost 12 years in my hospital, until one day I said I have to be number 1. And I don't want to take your position, but I want you to make me number 1 in the department that I am directing, that I have formulated, which was the clinical trials unit in my hospital. Of course, the answer was no. So, and the next comment was go to the administration and ask for it, but it's going to have to pass through me. And of course, thankfully, the administration heard me because I had the strength to go and ask for it, and I got it. And since then, I'm directing my own department. And I was very lucky to be in a situation where several other women in my country at about the same age group were starting to realize that we can't always be number 2. We have to make that step and ask and go for the leadership position. And at that point of time, which was around 2014, 2013, ESMO at a European level had started realizing that there are many women choosing oncology as a career now. So we have to take into account all these women that will be the main force of our members in a few years from now, and that's the reality today. And that's how the whole story with the ESMO W4O committee started. At the same time, with another 5-6 colleagues in Greece, we started a group. So we have a life of almost 10 years now in Greece with the Greek group, and a similar time frame is with the ESMO W4O committee. So I'm very, very honored, and I'm very happy to be here with you today. And I really congratulate you for starting this initiative. I remember having these discussions with you because, you know, UK is my second home, and I was really annoyed and angry that the UK was not present in the European things around women. So thankfully, we will start collaborating, and a lot closer now that you do have a group, and you will be able to map and see the situation of women in oncology in the UK, and start doing something about it as a group. So let me share my slides if I don't lose connection, because I had some problems before, but let's see if we can manage. Okay.
They're coming. We're definitely seeing your screen, Helena.
Okay, perfect.
But not your slides as
not
yet.
The slides yet. Okay, yeah, so give me a second. There we are.
No, so we're 10 years behind Greece at the moment, and
yeah,
so we've got some catching up to do.
yeah, exactly.
Yeah,
but
through now we can see.
Yeah. Okay, perfect. So
if you just go to
yes, slideshow, there we are. Okay, so I don't need to remind everyone that the gender equity story in healthcare is a long one, but what I have to say is that today the overall pattern globally in science, in medicine, and in health is one of mixed gains. So we have done some things, you know, we're not as we were 10 years ago, but we still have persistent challenges. And the main fact is that women are still substantially underrepresented in management, in leadership, across the health workforce. And this is not something that we dreamt or we think is happening. There is very strong evidence today, with many publications, with many advocacy groups around the globe, that this is true. And it's also very true with very strong, solid evidence in medicine. And as I will try to show you, it's very true also in oncology. And the other important fact that we have to remember is that there is a lot of solid evidence, and I'm stressing that because when we go out and we ask for things and we present our arguments, we don't just go and say gender equity matters because it's fair. because it is, of course, but we also have very solid evidence that gender equity in the workforce promotes economic growth, improves productivity, innovation, decision making. In medicine, we have evidence now that when we have a gender diverse workforce, that translates into improved patient outcomes. So there's a solid argument that we can present. And of course, any organization that is gender diverse has direct access to talent that will otherwise be missed. And I think that in one sentence, gender equity is a key to achieving excellence. And I urge you to have, whenever you advocate for things in your workplace or at national or international level, get all this evidence because it's there. So ESMO has, I'm proud to say that has contributed quite a lot over the last few years to gathering all this evidence and creating all this evidence about the situation in oncology. So the ESMO W4O committee, as I told you, was initiated as a workforce initially from Martine Picard back in 2013, just to investigate what is happening with all these increasing numbers of women members of ESMO. And then in 2015, this workforce became a group and then became a committee. And why is that important? It's important because committees it's actually a permanent committee. Permanent committee within the ESMO society means that the chair of the committee has a permanent position in the ESMO Council, which is the highest organ of the society after the executive board. So that shows you and symbolizes the importance that this committee has within the ESMO society things. So what we do is we raise awareness and we promote equal access to career development opportunities for women in oncology. And we actually provide a platform for networking with other women oncologists across the globe and with national or local initiatives. And this is the committee now. As you will see, I'm sure you will recognize from the faces and from the names some very prominent women and men leaders. The committee has a core members that you see there, and we also have an extended committee from leaders that have been members of the W4O committee for many years and are staying with us to advise and support our actions. These women are all volunteering their time, and I tell you that we meet almost once or every 2 months. We have many actions over the year, as I'm going to show you, and you can imagine that this takes a lot of our very, very precious time. I also want you to realize that this committee is not just a European committee. ESMO has global membership now, so this was mirrored in the membership of the committee, where you can see women from around the globe trying to translate the membership from Asia to the States, Europe, Africa, and around the globe. So we have come a very long way over these 10 years with many activities, with forums at the ESMO Congress, with meetings and forums now at the ESMO Asia Congress. And I'm sure that some of you that have participated in ESMO have had the chance to be in one of these interactive and I think very inspiring meetings. What we do is we observe, we report, we try to inspire, and of course we try to support women in oncology across the globe. How we do that? We do that, first of all, by monitoring and sensitizing the community on the gender imbalances that exist. So we act as an international observatory. We have monitoring studies for many years now, and I'll show you some of our results. We have surveys that we have published over the years. And of course, we have forums and interactive talks and virtual roundtables. We also educate and train. We participate in the mentorship program of ESMO very actively. We have sessions together with the Young Oncologist Committee, and we also participate in the virtual mentorship program, where we have specific schemes for people that want to gain access to leader women or mentors that are going to be women. And as I said, we have now a permanent session at the ESMO Congress, which is not something easy. Of course, the Congress, the forum happens every year, and we have established over the last few years not to have it, at 8 o'clock in the morning or late at night on the last day of the Congress, but now it's on Saturday at prime time. So please, when you come to ESMO this year, come and join us on Saturday at lunchtime, just after lunchtime, for the Women for Oncology Forum. We also have a forum now at the ESMO Asia Congress every year. And as I will show you, we have many interactive sessions around the year and virtual roundtables. And also, what we try to do is to provide resources and establish collaborations. And I think this is where we come for you as a group as well. We are trying to bring together people with diverse skills, and we are trying to address gender inequalities at a global and local level and help any way we can the local initiatives. There are many publications, most of them are in ESMO Open from the committee. And these are two of the most recent ones, which actually describe the results of the surveys, the international surveys that we have developed over the years. And basically, the surveys are trying to address all the challenges that we have in our oncology career, and trying to address all the factors that might be barriers in the development of the career of an oncologist. The surveys are addressing both men and women across ESMO members, and I'm sure that in some of them, and hopefully the last one, many of you have participated. And what we have found from these surveys, and what is the common issue, the common fact, the common result, conclusion from these surveys, is that it doesn't matter how many factors we put and how many factors we investigate, how many diversity issues we address, gender remains the main barrier even today to career development. It's not ethnicity, it's not sexual orientation, it's not religion. They are very important, and all the diversity issues are very important, but gender is the main one. And of course, gender is still a barrier for leadership. And I think that this is very important. This is the work of one of our monitoring and authorship studies that we've done. We have been doing over the last 8 years approximately. And we presented the results of these latest studies in ESMO this year in Barcelona. And look out for the publication, which is coming over the next month. So this monitoring study, what it is actually data that we collect on women representation in leadership positions, where either at national or international congresses as invited speakers, but also as board members or presidents of national and international societies, and also within the ESMO. So what we do is that we connected over the years with many societies. 56 international and national oncology societies have agreed to give us those data about board composition and presidency. And we also monitor the presence of women as invited speakers in 42 national and international congresses organized over the years. So we presented data, and we're going to publish this data, as I said, now in ESMO Open in the next month, from 35 congresses with 6,500 speakers, so it's quite a lot of data, and from 50 societies with 607 board members. What we found consistently is that women remain significantly less likely to be invited speakers at congresses compared to men for all of these years. Of course, things change. We are better than 2014, but still we are not where we should be. It's 41% of the invited speakers overall are women, and 60 or 59% are still men. What about board membership or presidency of oncology societies across the years? Again, women are significantly less likely to be board members or presidents of oncology societies. And there is a significant regional effect in the national societies. So American societies have more women in their membership, in the board membership, but also as presidents, compared to European or Asian ones. In 2022, where we have the last data, 34% of the societies that we investigated had a female president. That's not bad if you consider that back in 2016, it was only 10% of the oncology societies that had a female president. So we've done a lot over the years, but still 1 in 3 is not good enough. Another great area of interest, I think, is the contribution of women oncologists to research. And for that, we're doing these authorship studies. Again, it's over 6 years now that we're implementing this search of data. And what we do, we actually look for the first and the last author of publications in these major oncology journals. We added 3 more journals in 2020. And I think you will agree that these are some of the most important journals in our specialty. So what have we found? We found that women are only about 30% of PIs of research grants, which is extremely important, but also that female authors are significantly less likely to be last than first authors. So things have improved over the years. We are first authors as women, but we're not last. What does that mean? It means that we are not leading the studies. So we are not leading research. And this is extremely important. We are still not represented where things are happening and where decisions are made. So the conclusions from all this work is that there is some progress towards gender equity in oncology leadership. However, we are still not where we should be. Gender remains the main barrier in career development at both regional and international levels, and we still to continue monitoring so that we can act and have solid evidence, as I said, for what we are seeing and what we are realizing. And there is something else that have come up from these surveys and these studies, and we do have a problem. And the problem is harassment and discrimination. And I have to tell you that this has been a very difficult road, but it was something that we noticed through our surveys, that the reporting of harassment has increased from 40 to 50% in just over 5 years. And that is not including the unreported cases, all those cases that people don't report because of fear or because they think that nothing's going to happen if they report it. So it took a lot of courage and a lot of work and a lot of persuasion and a lot of ups and downs, but we managed as a committee to create a survey on harassment specifically, and only on harassment and discrimination in the oncology workplace, which ran with difficulties in the last few months. And now we have the results and the analysis, and I'm happy to say that we hope to have the publication soon, after it goes through all the scrutiny of approvals, of course, as you realize. A very sensitive issue, but there is a problem there. These are all publications from local groups, because we have realized the importance of identifying the different needs and the different challenges we have as women in different oncology fields. So we initiated a series, and we persuaded the editor of ESMO Open to accept this series of publications from different women groups across the globe. And you can see here the Indian group, the Spanish, the Italian group. So we have this as an open process, and we're trying to encourage local groups to present the situation in their country with evidence. And of course, the other thing we have initiated over the last couple of years is these roadshows, the virtual roadshows, which started in the period of COVID, just after COVID. And now we have established it as a regular meetings every 3 months, with local groups organizing the meeting and basically creating a virtual roundtable for the specific region where oncologists can come and discuss the specific problems and connect with us and discuss and create these networking opportunities, which you can understand that for certain areas of the world are extremely important and have been the way of them to create and start organizing their own groups. This is a reality for the W4O group in Egypt, where they now have a very strong women's group that is actually embracing women from all over Africa. And similarly, from women in Asia, where they started important groups, and also in Latin America. So collaborating with our committee, I think it's important. It's important because we have done lots of things over the years, but it's also important because it brings us closer. We create these the links. We can participate in meetings, have opportunities to exchange ideas. A group like yours can be listed in the ESMO W4O section on the ESMO website, and that will increase visibility of what you do, and also increase visibility so that you can bring more women from the UK together. We can cross-promote all relevant activities, and of course we can have the possibility to initiate several joint projects. These are the contacts, and please feel free to contact me in my email or through ESMO for anything that you think that we can help you. All the members of the committee are very happy to assist and help with ideas or advice on what to do and how to promote your actions, and with everything else you need. We are there to support each other. And one word that we have initiated is not just mentoring, it's sponsoring. We don't just need to have women mentors, we need to have women sponsors. And that is extremely important. And allow me to have a couple of minutes just to show you some of the things we do in Greece with the initiative, the local initiative in Greece, which was also started in 2014. And actually, it was initiated within the National Society as a workforce within the National Society. But since then, we became an autonomous non-profit organization, and we have members from all over, from all the different specialties around oncology. And we have a dual scope. We have, in Greece with the financial crisis, many patients, many female cancer patients didn't have access to not only to healthcare, but also to tests, to many tests like genetic testing is not covered by the national health system, and many other needs. So we decided to act as an organization that will support not only women oncology professionals, but also female cancer patients in Greece. And it was a very clever thing to do at the time, that we created this social committee, which was attached to the scientific committee. And this was a committee of renowned women of power and influence from all areas of public life outside of medicine, politics, media, art, literature, theatre, sports, and all these women acted as our ambassadors and supported and promoted our scopes, going up to the First Lady of Greece, which for many years supported us and created opportunities for our group to do things in the country. And we had the chance to create this social fund, where we managed to cover, since 2015, more than 500 women for free for BRCA testing, and actually advocated for this to start being covered by the national health system. And we are proud to say that for the last couple of years, this testing is being covered in Greece, but still there are many uninsured and women with no access that we still cover from the social fund. And 1 minute just to show you some nice photos. We travel across Greece. You know that we have many lovely islands, so we've been going to remote islands, providing advice and connecting with local women, doctors and not. We have done many interactive workshops on the value of prevention, exercise, diet, smoking. We have a workforce within our group that mapped all the oncology services across Greece. And this is available in this platform that we created. And also have done many campaigns about prevention in an era when all this was unheard in Greece. And campaigns in media. Why, you will ask me, is that important? First of all, of what it is, which is important, but also because it brought us together. We had a common mean, a common plan, a common interest, and that empowered us, gave us visibility, which is also extremely important, increased our trust to our own abilities. And of course, we had a lot of support. Here you can see these are pictures from one of very famous artists in Greece, which actually dedicated a whole concert in Herodion, the ancient theatre in Acropolis, which raised quite a lot of funds for our scope. And as I said, this is something that has created this core friendship between us, and a way of supporting each other and bringing closer to us many mid-career and young and other young women. So this is my last slide, basically saying that sharing the power is extremely important. How do you do it? You be the change you want to be. This is something that we always say, but I think most importantly, believe in ourselves. Try to change all these stereotypes and the established beliefs that keeps us behind, and try and get in front, finding strong allies and involve everyone. So I think I'll stop here, and I'll be happy to ask to answer any questions you might have.
Wow, thanks, Helena. What an act to follow for the UK, and what you've given us is so many ideas and so many opportunities that I think we can capitalise. Yeah, people are already applauding. Any questions from our audience? I'd really like people to kind of have an opportunity to ask Helena, because then when you meet her in Berlin or on one of the webinars, you really feel that you know her and that you can ask questions. You don't have to be embarrassed about whatever you're feeling. Just whilst we're waiting, please do think of some questions, and maybe from some of our resident doctors. But Helena, when you went and asked after 10 years, and we have to ask, it doesn't always come naturally, what was it that how did you kind of get yourself together to ask? And should you have asked 5 years before?
Exactly. I should have asked 5 years before, and I was being told by many colleagues, and also by my junior colleagues, because I was basically running the clinic, and all my junior colleagues were saying, why aren't you the boss? And why, you created this department? Why aren't you directing it, officially? And I was saying, no, we all have to be together. I owe him so much, and all that crap that we, put ourselves in. And then one day, enough was enough, because something happened. Someone asked me to go. Actually, I remember exactly what it was. Someone supported me to go to ASCO, which was a big thing, at the time, and didn't support him. So that was huge, because he actually called the person that sponsored me to say that you can't support her, you have to support me. So, that was the icing on the cake. And that's how I went, and I said, look, come on, this is becoming ridiculous. I've been number 2 for so many years. I've got my own department. I have to be directing my department. And thankfully, the administration, acted, supported me and not him. And now, after so many years, we are still in the same hospital, 2 different departments. And now he realizes that he should have acted differently. And at least, you know, we are in speaking terms and we collaborate. Yeah. But it's not easy. You know, it's not easy. No.
Corinne, come in. Welcome. Can you just say who you are?
Yes. Hi, I'm Corinne Cleverfin. I'm a professor of thoracic radiation oncology in Manchester. We've been in touch via Solange recently, Helena.
Yes.
So you were talking about the lack of leaders in oncology in general. So I had a quick look at the ESMO presidents. Since 1975, I could identify 2 female presidents, which is absolutely shocking. So it's great that you have this initiative, absolutely fantastic and very much needed. But then, you know, women are not putting themselves forward or are not elected. So I guess the question is, what are the solutions? Because we talk a lot about, you know, things like mentorship. You're absolutely right to talk about sponsorship as well. But we're not really making that much progress. What worries me about the literature and the numbers, when you look at the numbers, whether it's ESMO or other societies, is that things aren't changing that much.
Yeah, you're absolutely right. And actually, I'll tell you that the next 3 presidents of ESMO are men. So for the next 6 years, ESMO will have male presidents. And that means that half of the executive board, which is where all the decisions are made, are men. And this is a huge failing because we have managed over the years of Solange's presidency to create some rules that are becoming a policy of ESMO. So we have created this rule of a minimum of 40% presence of women in all the committees and all the meetings and everything. But that means that there are a lot more women in higher places, but still we are not going for the highest. Women are not coming forward or are not being nominated or are not being elected. But I don't think it's a matter of election. It's the matter of getting in front, going for the position, applying for the position, or being nominated from your peers. And we still have that problem because even in the, you know, in the committees that nominate, there are many women now, but still women don't nominate other women. So, you know, there is an issue there. And that's why I'm saying that we need to believe in ourselves and we need to get this false stereotype out of our head that we can't be good enough. We are good enough. There's a huge pool of women from which we can choose and nominate for these leadership positions. Similar in other societies. I'm involved in the ISLC, and now is the process of nomination. It's the same story. You know, for the nomination of the board, there are no women going forward. There's only men. So, you know, we have to go forward and believe in ourselves. That's number one. But it's also, it's not just, you know, I'm not trying to say, and don't get me wrong, that it's our fault. No, definitely not. It's also that we need to get rid of this stereotype, and that involves everyone, involves men and women. You know, we have to change the perception of both genders that we are doing different things or we're good for different things. We're not. We're equally good for everything. So, you know, the stereotype that, you know, we provide, they lead, no, not anymore.
Yeah, no, I totally agree with everything you say. I think another problem is that it's not just women don't believe they're good enough. I think there's also the issue that women also want to protect, you know, their own lives, and they often consider these positions that are extremely political as something that may tip the balance, you know, the personal work-life balance may not be good for their mental health. You know, I've certainly had that discussion with many women.
And Corinne, I think, you know, as a senior leader, I think that is an important thing, because obviously we're paving the way for our residents and our future, but actually for many of us, we would like to make sure that everybody at our stage is reaching their potential. So we'll get in touch, because I think there is a responsibility on us to call that out, but with the data and in a meaningful way. In the interest of time, I'm going to move on, but if there are questions for Helena, please keep that chat going. And I would encourage people to go to Berlin and meet people in Europe. It's just fantastic. The other thing that it just made me think of, that is the kind of example of these presidents of ESMO. but what is happening every day in your little meetings. And I won't share the story of what happened to me the other day in a meeting, and that is happening every day. So it's how we kind of work together to pull that. But it is my we must move on. That was absolutely incredible, Helena. I could ask you a million things, but I can't. So, Bookie, are you ready? And Bookie, read her her bio, hear all about it. This woman is incredible. What she is most proud of, she was telling me, is that she's a global oncology advocate. And if you follow her on LinkedIn, like I did, and that's how I got to know her, it was really what she is sort of doing to really support oncology across the globe and address health inequalities. But Bookie, you're gonna tell us about it. Over to you.
Thank you so much, Helen. Thank you, everyone. I'm so honored to have the opportunity to speak to my peers today. A lot of people who have been inspiration to me, my journey as a woman in oncology. And I think we've already heard it today. There remains a vital need for more health leadership by women around the world. Healthcare globally is mainly delivered by women, but led by men. And this is so glaring. And my talk today is really about empowering women to drive change in cancer care. So today I would highlight some unique strengths that women possess in the field of oncology, explore how to become effective advocates, and enhance our impact through education and mentorship, and also discuss some strategies for balancing professional and personal life. So a little bit about my background and my journey. So I'm something called an international medical graduate. And what that means is that my primary medical degree was in Nigeria, where and when I finished, I went off to Republic of Ireland, did my internal medicine training, and then went on to do medical oncology training. And afterwards, I decided to go to Canada, to Princess Margaret, to do my fellowship. And I did a dual fellowship, 2 years of drug development and 2 years of sarcoma. And while I was there, I knew that I needed to do more. You know, I've come from a low medium income country, but I was living in a high income country, but I was seeing so much disparities, and I knew that I needed to do something about it. So I went to University of Toronto, did a postgraduate diploma in global health education, and then also I got in contact with the Canadian Global Oncology Network, and they were doing this Global Oncology Leadership Development Program at that time, and I got involved. And since moving to the UK, in line with my leadership, I've done an MSc in healthcare leadership. I wear many hats. My day-to-day job is really a consultant medical oncologist, and I treat breast cancer, I treat sarcoma, and I treat germ cell tumors. I'm also the head of breast oncology at the University Hospitals of Leicester NHS Trust. I also lead the breast cancer clinical trials portfolio. I am a PI and sub-I on several early phase trials. I also work with the University of Leicester as a honorary senior lecturer, and I do some work in translational oncology. So I'm a clinician researcher. But the one that has taken the part of my career that's taken flight over the last few years is just being a cancer advocate and a health educator. And it brings me to this in terms of understanding our strength as a woman in oncology, because women in oncology, we bring a distinct quality and perspective that is pivotal in patient care and advocacy. You know, understanding the strengths would enhance our contribution to the field. And the first, and I would say the biggest strength that we have is empathy. So empathy is a powerful tool in oncology that enables practitioners to connect with patients on a deeper level. And this patient-centered approach fosters trust and enhances overall care experiences. And this leads to better patient outcome. So I will use an example of breast cancer. This is the most common cancer worldwide. So as a woman in oncology, you would have connected in some way with someone who had breast cancer. But with any other malignancy, women feel more comfortable speaking to another woman. And they also, it's more comfortable sharing the lived experiences. My mother passed away from breast cancer at a young age, but her empathy and resilience has always inspired me. And our job as a healthcare provider is to understand another human so profoundly that we touch their souls. Make no mistake, empathy is not weakness or being woke, but like what I say, being woke just means that you give a damn about another person. And I've put this little card that I got at Christmas from one of my patients, and it just encapsulates how patients feel when they know that you care about them. It makes them feel valued and understood during their treatment journey. The other power that I think we have as women is our collaborative approach to problem solving. There's that thing that says the women multitask, but it's true. Women often excel in collaborative environments. We leverage teamwork and we solve complex problems. And there are no other fields, I would say, that have complex problems such as oncology, because oncology is a field where resources are finite, treatment is so expensive, therefore innovative ideas are needed in order to build a lasting framework. Also, female leaders have positive effects on financial performance, innovation, ethical practices, health, organizational culture, but most importantly, they're interested in women career outcomes. Another power that we have is our resilience and adaptability. Oncology is such a demanding field that requires this resilience. Women in this profession, we often navigate challenges with grace. We're using our experiences to inspire and lead others through adversity. And also, it's been ingrained in us to push past our own desires and even sometimes our own health to focus on our families. I'm not sure if this is a culture we should encourage going forward, but it has helped us build resilience and adaptability. We've talked about Helena, and Helen also talked about being advocates, and I think that it's very important. Being a global advocate is an aspect of my career that I have excelled at, and I believe everyone should be an advocate, because when we look at cancer inequalities, it is everywhere. I know sometimes when we say global oncology, the first thing you think about is low middle income countries. However, that's not true. Even here in the UK, it's staggering the amount of disparities that we see. And with almost 3.5 million people in the UK living with cancer, people are finding harder to deal with because of who they are or where they live. And I think it's never been more important to bring the voices and experiences of people living with cancer into shaping cancer care for the future. So a little bit about what cancer health disparities is. It's unfair, it's avoidable, and these differences we see across different populations, and it impacts on physical and mental well-being. It impacts on outcomes, it shapes our experiences, and I usually say where you live should not determine if you live. And the ways that we can effectively combat cancer health disparities is that as advocates we must first identify the specific inequality present in your sphere. And a lot of this involves understanding the demographics, understanding social economic issues, cultural factors that contribute to these disparities. I normally would say cancer does not discriminate. However, we see significant differences in access to care, treatment outcomes, and survival rates. And these disparities are mainly rooted in all of the systemic inequalities, and someone living in Derby should not have a worse outcome than someone living in London. We should all have equal access to care. So these are some of the things I do in cancer health disparities. It's not an exhaustive list, but it's just to show an idea of how we can do things and how we can make difference, regionally, nationally, internationally. It's very important. And it's all about building partnerships and networking, creating strong partnerships with organizations and individuals worldwide is very crucial in raising awareness and implementing effective solutions to cancer health disparities. Collaboration enhances resources sharing and would maximize the impact. And there's no way we're going to talk about cancer health disparities that we're not going to talk about policy change. It's beyond just raising awareness, but it's influencing policy change, engaging with policymakers and advocating for equitable cancer care. We as women can drive significant improvement in health outcomes. When I came to the UK, one of my aims was to highlight intra-country cancer disparities. And the meeting that I organized last year in November at the House of Commons as part of the London Global Cancer Week was to raise this awareness. Another way that I've been trying to influence policy change is that I've signed a petition for the UK government to fund breast cancer screening from age 40 and alternative screening options. Breast cancer is no longer a diagnosis of the elderly, and the incidence in young women is rising. As a breast oncologist and researcher, I have seen firsthand the devastating impact of late diagnosis on individuals and their families. So please, I'm using this opportunity to ask that you join this movement, sign this petition. The system doesn't work for everyone, and we're seeing the impact of this true unacceptable cancer care gap. We're talking about the National Cancer Plan in the UK. And I think it's a great idea. And I think it's an opportunity to bring the whole cancer community together to fix this and set out an ambitious vision for the future. We need to put the voices of those who have had the worst experiences front and center in the development of this plan. I think we cannot talk, we've all talked about mentorship, sponsorship, coaching. We can talk about our strengths as women without talking about education and mentorship. It is vital in shaping the future of oncology. By sharing knowledge and supporting the next generation, we as women can make sure that our impact resonates well beyond immediate reach. I've been very fortunate to have excellent female mentors in my career journey. However, the coaching and mentorship sometimes was very difficult as they didn't understand my background or culture, and senior leaders provide a model for their followers, and this should reflect the communities that they serve. So diverse representation in leadership really matters, and that's why I've taken it on myself to mentor young ones from ethnic minorities, because I've walked their path. There's a shared experience, so I have juniors who I've helped to present at international meetings, who I have asked to join me, collaborate on grants, on projects, and also helping them become associate PIs. And one of them has received a CR UK fellowship. So as women, educating peers and next generation of oncologists is crucial. We play a significant role in educating, and by sharing these experiences and knowledge, we would contribute to a more informed and prepared workforce in oncology. Because you have to remember that cultural expectations and social standards add additional pressure on us as women. There's a strong emphasis on traditional gender roles within the household, and these challenges make it difficult for women to advance their careers in specialized fields such as oncology. So this is really important, and mentorship would help a lot, providing guidance, support to encourage growth. We have to talk about professional and personal life sustained impact. We have to balance. Oncology is such a demanding specialty, and one of the things that have helped me, because people ask me, how do you juggle everything that you do? And this Japanese concept of ikigai is what I go by, connecting with your values, trying to find that sweet middle ground of everything that you want to do between your profession, your passion, your mission, and your vocation, but staying true to yourself. Because if you don't stay true to yourself, you will burn out, and you won't derive any pleasure in what you're doing. So there's some strategies that we can take to help with work-life balance, implementing effective time management, prioritizing strategies can help oncology professionals such as ourselves to maintain a healthy work balance, reducing burnout. But I usually say, I mentioned earlier on that empathy is one of our strongest points or values and tools. However, it's also one of the things that make it difficult for us because we don't know how to say no. It's just so easy for us to keep taking things on board, but it's okay to say no because self-care and mental health awareness is very important. We need to take care of ourselves, and self-care can be in several ways. It can be setting boundaries, it can be putting yourself first, it can be asking for what you need, or asking for help, or even taking a step back. It's important as women in oncology. There's pressure from family, there's pressure from work. We need to self-care and have that at the back of our minds when we, do all of these things that we love. Most importantly as well, one of the things that can help us is a supportive professional network. It offers invaluable assistance in navigating this challenging career in oncology. And this network can provide encouragement, resources, shared experiences. And this is the reason why we're launching Women for Oncology UK group. And, Helen and Selena have already shared some of the things that Women for Oncology UK group can offer. So in conclusion, I have to say that women play a vital role in oncology. We bring unique strengths and perspective to the field, and women in health will continue to face penalties for motherhood. We will continue to have lack of recognition and support for leadership bids, fear of promotion, and exclusion from the old boys club, I would say, So we need to stand up for ourselves. Change is not a responsibility just for women. It's a responsibility for everyone. And it's clear that more women appointed to leadership positions would drive transformative change in this kind of bias system that we have. And like I said, my advice is be passionate, be dedicated to your work regardless of gender. Find mentors who can provide guidance and support, and do not hesitate to seek help when it's needed. Build a strong professional network by attending conferences, joining professional organizations, collaborating with colleagues. All of these are essential, and I think it's important that you remember that your contributions are valuable, and developing that unique perspective is essential for your growth in the field of oncology. Thank you for your time. Any questions?
Wow. And just complimenting, what Helena said, but in a different way. Absolutely love that, Bookie. Congratulations on everything that you're doing. Any questions? Adeniki, do you want to ask a question? You're clapping.
really enjoyed that.
Yeah.
Thank you so much. It was very informative, and seeing that expertise brought in as well, giving me some ideas myself. I've been taking notes. The question I have really is about how to incorporate advocacy as a training. So I'm just introduce myself. I'm a clinical trainee, STFI. I'm currently out of program doing a PhD in Holyoke Medical School of Pancreatic Cancer in Genomics. I do like the idea of global oncology and advocacy, but how do you incorporate that into training? Because it's not something that you do day to day. It's not something that's talked about. Sometimes it feels like a side hustle rather than something that's incorporated into training. So your thoughts on that will be very welcome, please. Thank you.
Great comment and great question. So Buki, do we need to look at the curriculum? I mean, we've just, for many of us who've been involved as TPDs in medical oncology, they launched a new curriculum, but almost as soon as it was launched, you might argue it's sort of out of date. And how do we advocate for that? Because
absolutely, it's important, honestly, Helen, because like Danica said, it almost feels like a side hustle. And I usually say this is something that I do that I'm not being paid for, but it really should be something that everyone should be involved in, because like I said, disparities is everywhere. You just need to look. So even in breast cancer, so I treat breast cancer. Even in breast cancer, the amount of effort and support in early breast cancer is different from secondary breast cancer. So you just need to look around you and you will see the need to advocate. So you're right, Helen, we need to look at the curriculum. We need to start putting this, and maybe even the way we say do an audit, maybe we start saying do an advocacy thing or something to let people have it at the back of their mind that this is something we need to do, almost the same way we're doing quality improvement projects.
I absolutely love that idea, and that should be reflected in our interviews, reaching out to our communities, actually addressing and listening to our communities should be up there with doing an audit and those other things. I love that, and I think there is some influence that we might be able to exert on that. Any other questions? Buki, in 5 years' time, you might not know what you're doing tomorrow, but in 5 years' time, what are you going to look back and presenting the 5th annual meeting? What are we going to hear from you?
Oh wow. I think it would be definitely the fact that what Helena said, we're going to have seen a change where, we'll see more women leaders. Like I said, healthcare, 70% of healthcare is delivered by women, yet we don't see women in positions of leadership. So I'm hoping that in 5 years, when we're having this conversation, that numbers would have flipped. And we'll be able to say that, remember 5 years ago when we had this conversation, this was what it was. Now things have changed. Women are now last orders. Women are doing this. Women are doing, because as women or as human, we get inspired by what we see. So how can the upcoming generation get inspired if there's nothing to inspire to? And that's one of the things that we have to remember every day, that we hold ourselves accountable to make sure that the next generation doesn't suffer for our own making ourselves small, in a way, because we're not small, we are massive. We have a big light in us, and we need to show that. So we need to show the giant in us, so that the people coming behind us can see that and do better than what we've done. So I'm hoping in 5 years, these are the kind of conversations we'll be having.
Yeah, and maybe President-elect Buki for ESMO. So our final speaker, building on this clinical leadership and ability to influence, is Penny. He's already achieved so much. And again, you can read about what she's done, and she certainly may touch on that. But what she wants to be known as an oncology leader with integrity. It's absolutely important that we continue that integrity and are known for delivering, but in that fair and honest way, and that fundamentally at it all, she is an oncologist who wants to deliver for patients and families. So in whatever direction we go, that is at the heart of things. And Penny, I'm going to hand over to you, so do start sharing your slides, but I just want to mention something, because Bookie's already done a shout out for her petition. I just want to mention, if anyone is in a leadership role and can do anything to offer cervical screening for our workforce, people in our NHS and social care, Isabel Wood, who was a resident doctor, came to me at the Cancer Alliance, and we have done that in pockets. But what we would like to see, and this is from an alliance perspective, is that we are advocating for women working in health and social care can have access to cervical screening. I will share some data on it another time, but if anyone is in those positions where they could do something to say that we know a number of our health workforce are not accessing cervical screening in a timely way, and we'd obviously like to extend that to women in social care. But that's enough of that advert, but I just had to shout out, and that's come from Isabel Wood, who's not joined us tonight, but is just an amazing resident doctor. But Penny, over to you. Psychological safety in the workplace, bringing us home this evening.
Thank you, Helen, and thank you. Fantastic work from your side, and fantastic leadership to launch Women for Oncology. Really proud to be a member of, and thank you to Helena and Bookie. Fantastic presentations as well. I'll tell you a bit of my story. I'm a consultant clinical oncologist in the NHS, and I have been a consultant for the last 14 years. About 22 years in the NHS, and I hold several medical leadership roles in the NHS private sector as well as voluntary sector. One of my passions is leadership and how leadership can lead to innovation and change. I've done a PhD at Warwick Business School around leadership, but I'm also very passionate around compassionate patient care. And I chair a charity called the National Centre for Integrative Oncology, which is about bringing together supportive oncology therapies, complementary therapies, alongside our standard oncological treatments. But tonight I want to talk about psychological safety. And why is that? So I'll tell you a bit of my story. I grew up in Greece like Helena, and I left when I was 17 and a half to come to the UK to train as a doctor. And I worked really hard. Really, I grew up in the UK, and I had plenty of opportunities clinically as a junior doctor. But when I started to get more senior leader positions, so consultant and then clinical director, and then later medical director, what I observed is numerous power dynamics within organizations and healthcare systems, and lots of politics, and often navigating those power dynamics in politics was quite difficult. What I observed was that women were not very good advocates for themselves. And also, if we are advocating, we are often accused as being aggressive. But what we are assertive and we are confident. So I had two choices. I met a lot of good leaders and a lot of bad leaders, and my choice was to either become a bad one and treat everybody else badly, or actually become a leader with integrity, which is one of my biggest values. And I made a commitment to myself that I'm going to be supporting the growth of people who want to become doctors or any other healthcare profession and grow and get into leadership positions, particularly women. So I mentor a group of postgraduate women at Warwick University. I coach, I'm a professional health coach, but I also mentor senior colleagues of mine. So I fully support what Ellen talked about, mentorship, but also having sponsors when you are a woman and you go into leadership roles is really, really important. So that's my story, but I'll start by actually explaining what psychological safety is. So the term is actually the belief that one will not be punished or humiliated for speaking up with ideas, questions or concerns, or even mistakes, and that the team is safe for interpersonal risk-taking. So the global leader for psychological safety, who wrote several books, and I believe she teaches at Harvard University, is Amy Edmondson. And actually, this is all about equity. This is all about giving people the opportunity to speak up, to challenge the status quo, and having the freedom to do so without being blamed of being difficult, of not having the right to do that. Now, we need to be careful of what psychological safety is not. It doesn't mean that we are allowed to make repeated mistakes with not learning from them, but it is about taking risks, and it is about making mistakes, learning from them, and improving. It doesn't mean that we don't challenge and we don't conflict, and actually conflict within teams can be quite positive, and it can generate ideas, and it can change perspectives, and it can give a better solution. So why we should strive to achieve psychological safety within teams, where there's plenty of evidence that actually achieving that state, it could prevent mistakes, or even lower harm from mistakes. Because imagine if you are sitting with your team and openly discussing risks and what can go wrong, or what really went wrong and why, then we feel that actually we are heard, we are supported, and even if we do our mistakes, we learn and then we move forward and become better. It also fosters diversity, thought and idea diversity, which leads to better outcomes. It promotes learning and improvement, and it's okay to fail. Actually, when I did my research on innovation and leadership, one of the essential elements of success and innovation is failure. And it's okay to fail and try again. So giving our teams that permission almost and the autonomy to try and fail until they succeed is okay. Living within that environment, whether it's personal or professional, it improves our well-being and improves our resilience, because we know even if we go away for a while, we are going to be supported by our colleagues, and that leads to more sustainable workforce and lower sickness rates. So there are 4 stages that Timothy Clark in his book talks about when we try to achieve psychological safety. So stage 1 is called inclusion safety. So really, this is about making everybody feel included, accepted, and respected. And there are several steps that you could take to do that within your own teams. It could be keeping frequent check-ins with your team. Allow everyone to contribute, and even the quiet ones, you can encourage them to contribute ideas. Being flexible with ideas, don't be fixed. Listen to others and get their perspectives. Be an adaptable leader, and it's important to be available as well and approachable. Stage 2 is about learning safety, meaning making everybody feel that they can take risks, fail, and learn from them. That is done without blaming people. Learning is a group activity, and it's important to share those learnings, but also what worked well and what didn't. Discussing risks openly and feeling comfortable with uncertainty. It's also making everyone feel that they can contribute. That's stage 3, the contributor safety. Every opinion and idea should be respected and heard. And finally, everyone should feel comfortable that they can respectfully challenge status quo. The term, this is what we do here and we cannot change it, it is no longer fit for purpose really in this developing world, especially in healthcare. So it's really important that we collectively and respectfully be able to challenge status quo. Now, you may have seen this graph, but that really demonstrates the degree of psychological safety and accountability and what is the best place to be when we want our team to be well, but also perform well. And being in an environment where there is high psychological safety and also high accountability, this is considered to be the learning zone, which is the ideal zone to be. Now, the dangerous place to be is that when you are working in an organization that you have to be really highly accountable, but also the psychological safety is low, which means you're always in fear that somebody may blame you for what has happened, or you fear that you're going to lose your job. Now, this is a really not a nice place to be, and that can lead to burnout, particularly in healthcare professionals. The other two zones, the comfort zone and the apathy zones, are the zones where growth really is unlikely to happen. That those zones stifle creativity really, whether it's high psychological safety but actually low accountability, you don't have the motivation to do more. And an apathy zone is basically nobody cares. So this is unlikely that it's going to be a growing professionally zone for your team and yourself. And this is Amy Edmondson, and she wrote a book around the three core leadership behaviors for psychological safety within the Phyllis organization. It's a great book to read. And she talks about the work, framing work as a learning problem, not an execution problem. So learning from improvement and improve next time. She talks about acknowledging that we are all fallible and we all make mistakes. And that makes you more grounded, that makes you closer to your team members. And finally, work with curiosity, ask questions, be curious, because curiosity will make you hear more diverse ideas and thinking, more perspectives, and you might find that you tackle problems in a different way and much more effectively. So why are we talking about psychological safety and why it is important for women? Well, there is plenty of evidence to show that women experience lower psychological safety in the workplace. I talked about power dynamics at the beginning, and this is true. And in fact, the retention of women at work increases 4 times when women feel psychologically safe in the working environment. Research also has shown that women leadership groups like Women for Oncology are really important and should be encouraged in the workplace. Finally, why psychological safety is important in cancer care. Where we live in a highly regulated world, we know that particularly healthcare is a highly regulated profession, and with that comes stress for healthcare professionals. They want to be as good as possible every single time, but that it's not possible. We all make mistakes, and it's about how we treat those mistakes. What is our behavior towards those? What is the team culture around, I guess, dealing with mistakes, supporting each other? So psychological safety within cancer care, it promotes teamwork, requires high quality communication, and that is between clinicians, but also between clinicians and patients. How do we ensure that we say sorry when something goes wrong, we are open about it, and we improve next time? Leaders' actions in the workplace, especially in oncology, they shape climate behavior within groups. It fosters patient-centered care. So if our main focus is how to ensure our patients are treated well and safely, then that's our value, and we work towards that common goal together. And finally, creating such a culture, if it doesn't exist, does take time, and it involves everyone's effort, but it's at the end really a state where clinicians, staff thrive, but also our patients get the best care possible. Thank you very much for listening.
That's absolutely fabulous. Any questions for Penny? Penny, what that made me think of about women and retention, and hearing that many of our health professionals are exiting even before they have completed their training. I'm particularly thinking of some of our nursing and radiography student colleagues. Is that because people aren't feeling safe? Or what contribution is that?
I would say that it's multifactorial, Helen, but we've got a tool in the NHS, we call it a staff survey. And the staff survey happens, as you know, every year. And it's really important that first of all, we encourage high response rates from all groups. And that has been the main focus in our organization, to ensure that we get that diversity of responses. But it's also sitting down with the people to understand where the challenges are. And I would say, the pressures of work that we face, oncology is already a really challenging specialty, right? We see a lot of challenging cases. We relate with our patients. We bring those cases back home. We reflect on them too much. But also speaking to colleagues in the emergency medicine, there is a lot of trauma that happens every day in clinicians, seeing people injured, seeing death. And unless we work and operate within groups that are supportive and actually, we try to see unbiased what has happened, rather than, it happened and we have to blame somebody if something goes wrong. I think certainly that brings a lot of stress, and with time it comes to burnout, and that is one reason why people leave, but it's not the only one.
No, thank you. Any questions for Penny? I'm going to ask you another question. Please do write in the chat. Jess, come on. You must have some questions. You like to chat. Have you got anything you want to add at this stage? I know you're going to come up with some reflections shortly, so maybe
trying to give everyone else a chance to chat.
All right, fine. All right, Jess, we'll do that at the end. Any other questions? I mean, I think what you were saying about making mistakes and being transparent about making mistakes, I'd quite like to ask our audience at some point, if people have been involved in complaints, I'm not really talking about legal complaints, but it feels often very unfair. So we're sort of looking at compassion in complaints, which I think, coming back to what Buki said, hopefully women can lead that, because particularly with the current pressures, mistakes are happening. And often I heard about something earlier in this week, and someone was sort of talking about it, and I was like, well, there, for the grace of God, go any of us with a mistake. So I just wondered if people have got stories that they would share with me, not now, because we're looking at compassion in complaints. And when a email comes through that says statement needed, I mean, I really have taken issue with this on behalf of several residents, actually, who've just been, received those emails out the blue. And I just don't think it's the way we should be practicing our medicine, because mistakes happen and very few people set out to create harm. And what we need to do is learn and share that learning, because I think it could kind of happen to anybody. So it really made me think about that, Penny.
Absolutely. And I think we all have received complaints in our careers, haven't we? Yeah. And when you read that letter, it is painful. It does hurt, doesn't it? And you almost want to say, but actually, that's not what I meant. And that kind of, moral injury comes in. Yeah. And, this is not what has happened, actually. But at the end of the day, is how the other person has perceived what you did. And even if you didn't do it, it's important to reflect, to discuss with colleagues, to seek support, and be able to sit in an environment where colleagues will listen and will see what you can see, but also draft a response which is not, it's not defensive. It's acknowledging that the other person has perceived it that way and apologize. And actually don't dwell on that anymore. Learn and let it go. I think that's important too, because sometimes we keep kicking ourselves that, this is not who I am. This is not the doctor that I want to be. And for some people, often it's the cherry on the top with everything else. And they say, that's it. I cannot do it anymore.
Yeah.
Which is the wrong reaction. And that's where people need to seek support from mentors, coach, the friends and the network.
No, thank you. Buki, come in.
Yeah, I just wanted to add to say that with the pressure on the system, mistakes are bound to happen. And I just tell my trainees that if you do get a complaint or if something happens, it's very important to reflect, reflect and make sure that was there anything or is there anything you could have done better, and be sincere with yourself, and also reflection is great because that's where innovation comes in, because it might be that you didn't do anything wrong, but then in your reflection you could find a way to make things better, so like Penny said, the initial reaction is that defensive nature and that moral injury, but it's good to look beyond that. And I always say, when I get a complaint, I never answer a complaint immediately, because my response might not be the right way to do it. So I take my time to reflect, so I let it sit for a few days and then I try to come back to it, so I think it's important. And Penny, it's so important, this psychological safety. We're already, as doctors, we want to help. So the probability that we want to harm someone is really, really low. And the system needs to identify that or acknowledge that fact and not witch hunt people. We've had people sit in M&Ms and people just want to cry and break down because the M&M leads is just trying to witch hunt people, so it's important that when we do find mistakes, how that culture of blame should shift, and how we handle it is so important, because it's a make or break for a lot of people, and suicide death in medicine is growing day by day, and oncology is such a stressful field, so we just need to be very careful, so.
You're absolutely right. I fully agree with you. We do live in an imperfect system. You're right. But often, the shortcomings of the system, we feel them as doctors, as senior clinicians in front of a patient, and even the delays in coming to the clinic, that can be unbearable sometimes, can it?
No, I think that, and I think having those open conversations and having that sort of how we build that culture of psychological safety here, so that we can develop as an organisation, is very helpful. So I think it's good to have these more open conversations about sometimes things that are really difficult, but hopefully that the way we evolve will be that we can support at least people in this sort of arena, some psychological safety. So I think that's really fitting that you've done that at the beginning as we form this group. Any other questions for Penny? If not, Jess, do you want to come in as one of the committee and just sort of add your reflections on what has been an incredible evening and some next steps and thoughts and how people might contribute going forward?
Lovely. Thank you for the introduction. I feel very privileged to go at the end of a webinar, having had kind of so many inspirational people at the different parts. I'm currently a trust doctor level, so post-foundation, pre-IMT, so it's always lovely to see people that are further on in their career doing incredible things, and a lot of those kind of pathways and paving the way, I think those of us coming after are very grateful for, if you're in positions that we'd love to be in kind of years time. And I had the task of, as the chatty one, I guess, reflecting on what everyone was saying, but there was so much, it was hard to kind of distill it down, which I think maybe an important part to raise or reflect on, is that actually everyone's got a different kind of passion project or something that is kind of deep within their lived experience, and actually joining a community together with that many different things that they're passionate about is something kind of great that we can drive forward. I've heard from kind of different people. From Helena, we spoke about kind of women sponsors and empowerment and visibility of women within kind of leadership roles. From Becky's talks, I really related with the idea of kind of peers and also who those people can be. So remembering that they're people from kind of across the spectrum of people that work in oncology and all kind of training grids. You've done kind of amazing things at all parts of your career. and kind of recognising that. I think it's great that we've seen kind of both Helen and Celine here as kind of the founders of Women for Oncology, and demonstrating that kind of it's never too early or never too late to be a woman in oncology, and kind of driving things forward. And then I think Penny did an amazing job at the end of kind of summing up kind of, I guess, the model that we want to bring forward in women oncology, of having that psychological safety and that network of women supporting each other that will enable everyone to do these amazing things we hope we're going to achieve. And I guess looking at some of those things that we could achieve, and I'm going to try hope that Teams internet works with me so I can share the slides to show you. So let's see if this works. She says, let's see if I can click through. Can people see my screen? Because I now can't see you.
I can't as yet.
Is that working? It might have to.
Oh, it's coming. It's coming. Great. Well done. Yeah. You're still on slide sort of view to me.
Might have to be.
That's fine though. It's absolutely fine.
Working.
Yeah. No, carry on, Jess. You're doing great.
Apologies, my tech setup is not as suave as everyone else's. See if maybe that one works. So we're kind of doing our looking ahead, I guess, at some of the things that we're hoping we can put into place as Women for Oncology UK. So the first thing to advertise is we've had our launch webinar today, but we're planning for kind of at least one quarterly. And so our next one, a date for your diary, is the 14th of May, with Sandy is coming along to talk to us about the topic of domestic violence and cancer, that we hope will be incredibly interesting for all. We're expanding our mentorship scheme, and I'm going to take this opportunity to shout out Caroline, my mentor who I saw was on the call. We met for the first time this week, and it was a very positive experience. I'd recommend everyone getting involved and meeting who yours could be. Speaking of kind of networking earlier, I've got plans for meetings and workshops for this, and patient advocacy activities. I'm kind of linking back to what kind of Bookie was talking about, you know, having those advocacy projects is important for everyone as kind of an audit and QI. And thank you for everyone that kind of had completed our pre-launch survey with your responses about kind of areas you'd love us to focus on. And other things, I guess, especially when we're talking earlier, I think Helena, about kind of visibility and empowerment, is we hope to see you at kind of lots of oncology related events this year. We're very proud to be kind of introducing the Society at the Bonus and Notch conferences in March. You can come meet us at a stand at the UK Oncology Forum in June. And then I think we're also hoping to be at the BOPA conference in October, as well as ESMO in Berlin. So hopefully from today, you can see how approachable and friendly and lovely everyone is. So please do come join us, be part of us, and come have a chat to us at all of those amazing events. And speaking of those events, we're hoping that kind of this slide has a few things on now, but becomes busier and busier with each kind of annual meeting where we talk about our future, but just some of the people that we're working with now. And things like Helena said earlier about working towards becoming much closer relationship with ESMO and their amazing Women for Oncology team. And then I guess why we're here is to kind of launch us as a network, but to kind of hopefully we've convinced you through our amazing speakers and talks to join us. And so about kind of what you'd want to see from Women for Oncology UK. And we'd love your feedback about that. We'd love you to join us. We'd love you to get involved in the mentorship scheme, and all of these things can be done by scanning the QR code. So what I might do is leave that on the screen a second. I don't know if Helen or something or someone else.
I can't see that code. Is it up for other people? If it is, that's great. But we're still on looking ahead, are we, Bookie? Yeah. So that's it. That's now there. So can people scan the code and give us feedback now for 2 minutes, so that we just capture everyone who's been on the call? I think we got up to about 70. Over 170 had registered. So hopefully we'll be reaching out to others, sharing some recording or the slides or some reflections on this. But do give us your feedback, because we've just scratched the surface in 2 hours of what we could achieve. I just feel so blessed to have been here this evening. I don't think we could have had any better speakers to launch this. Just Celine, I'm going to hand over to you. Final thoughts to you, because you've just been absolutely amazing. Jess, I thought your reflections were just spot on. Thanks for all you're doing. Thanks to the rest of the committee. Most importantly, thanks to our audience. And please do get in touch. We just want this to be a very informal network. And do give us your ideas, things that you've been wanting to deliver locally and haven't been able to do, perhaps regionally, nationally, internationally. We can do much more than we are able to in our own systems, challenged as they are. There's Corinne. Yeah, lovely. I'm delighted to meet you, Corinne. I think we've got a future speaker there. I don't know if she's still on. But Celine, thanks to everybody. Absolutely delighted. And last word with you.
Thank you, Helen. Now I just want to say thank you very much for everyone who's attended, and thank you for our speakers. All the talks were amazing, really inspirational, and I think has given us a lot of motivation to sort of see how far we can go and how much we can achieve with the society. I'd echo what Helen said, and it would be great to get feedback. And on the QR code, there's also space to fill out a form if you do want to become a member and join us and see what we can all achieve together. And hopefully we'll see you at some of the upcoming events.
Brilliant. Thanks, Helena. We're learning from you. I'm so delighted. Penny, Bookie, just keep in touch, and do share your emails and stories with us if you'd like. Amazing. And we finished early, which is even better.
Thank you.
Thank you.
Thank you, everyone.
Penny, unbelievable. Helena, Bookie, I mean, we couldn't have asked for better talks, honestly. It was like we'd kind of planned it much more than we probably had. But that was fabulous. Thanks, Celine. Are we getting any feedback, Jess? Could you just see? We can maybe put the code on LinkedIn, can't we, or something? Yeah, and share it. Amazing. What time is it there, Helena? It's bedtime.
Not yet. No, it's 9:30. It's 9:45. It's early. For Greece, it's very early. Life starts now.
Yeah, and I can't wait to see you in person. Hopefully all of us will be in Berlin. That would be amazing, wouldn't it? Yeah. We're going to be in Harrogate, we hope.
And send everything to ESMO so that we can list you on the website, so that we can start, co-promoting things.
Yeah, brilliant.
Yeah.
Great.
Super.
And we've got some other speakers. We've got planned speak. I think Penny would be a great speaker. We've still got people on, but I think we're going to leave. Everyone happy to leave? All right. Cheers.
Bye.
Thanks so much. Celine, Jess, we'll catch up. Thanks so much.
Bye.
Bye. Bye.
Bye. Bye.